All right, well, hello everyone. Got some exciting topics to talk about today in the grammetry and photogrammetry world. We're here with our very special guest, Dr. Isaac Tawil out of New York. And he's got, again, some exciting news to talk about. And before we go into that, I want to introduce myself. My name is Chris Moore from ROE Dental Laboratory. So why are we all here today? Well, we have a new product to release in the world of grammetry. We have a new product called ArchBridge. And initially we helped roll out a product from Digital Arches called the OptiSplint. And that was under our grammetry umbrella of products, which is a direct to multi-unit abutment connection for your full arch prosthetics using just your intraoral scanner. That's the end result, direct to MUA, very accurate record-taking process. And you didn't have to buy any big equipment to get that done. And with the ArchBridge, I'll let you kind of go into that, of course, Dr. T. But the ArchBridge is another product under the grammetry umbrella using just your intraoral scanner. So please introduce the ArchBridge to us.
Sure, absolutely. And I do want to say that we had some really great results with the Grammetry OptiSplint. It is a great device. It worked very nicely. We published the first paper on that topic about 3 years ago, I believe, 2 or 3 years ago in Dentistry Today. And we've had some great results with it. It's a wonderful device where we have the same scan bodies that are in the mouth, and then we link them together in the mouth with a resin base within a frame. And then we remove the entire structure out of the mouth and then scan it with a intraoral scanner, or even better, we can scan it with a desktop scanner, which unfortunately many doctors don't have. It's a great tool. Everyone should have one, but they don't. So we were using the iOS. And to finalize those cases, we would then send that out to a laboratory that does have a desktop scanner to capture. Using this concept, understanding that it's hard to get from one side of the mouth to the other side of the mouth without having interferences, without having interruption in scanning. If you try to use the same scan body, let's say you pick a typical scan body that goes on an MUA, it looks like a stick. It may have like little pretty flags coming off of it, but really not that much where we're able to connect from one to the other. So if you have a tooth all the way, or an implant all the way in the back, and then one all the way in the front, if you're doing it all on four, that gap was very difficult to connect to. We came up with so many different methods over the years of trying to link these things together. They never really worked well until the until the OptiSplint came out. The OptiSplint took us to that next level where we were able to actually link them together physically, then scan them. And we knew that we would get a great accurate scan from that. And if you didn't, you could always send it to the laboratory and they would get it for you. So it was a really wonderful method to be able to go from one side to the other without having this interferences. That being said, it is a little bit costly to keep doing that if you have a lot of cases every month, or if you're just breaking in and you just don't understand the concept, you just want to be able to scan bodies. And so what we came up with was having unique set of scan bodies. They're not made of aluminum like the OptiSplint, so the OptiSplint is not reusable. These are reusable titanium sandblasted, anodized, not anodized, but sandblasted and roughened type of a scan body that will allow us to be able to go from one side of the mouth to the other, utilizing different unique shaped scan bodies. What very often happens when trying to capture these scan bodies that are not differently shaped, we end up getting the computer confused. A lot of these different cameras have artificial intelligence built inside, and sometimes AI can be our downfall with these things. You could be scanning the right side of the mouth and it sees the same object, and you're on the left side now, and then it brings you back over to the wrong side. So what we really do want is something that's different and unique and identifiable. The other advantage of having this ArchBridge with the different shaped scan bodies is that as we're scanning, we're able to bring them very close together to each other so that we can go from one scan body to the other without having any disruption in our scanning process. So if we can go from the right side to the left side in one nice clean path, and then maybe go pick up some little side shots if you want. The key is to get a nice overview of where that scan body is, especially by the head. And when we scan by the head and we have a tail that's leading us to the next scan body, we're able to jump to that next scan body without any distortion. Then the lab can then take that information, which is not having to be transferred. For example, the OptiSplint, if you don't have a desktop scanner and you want to make a final, you have to send that OptiSplint over to someone who has a desktop scanner, preferably ROE Dental Labs, to make your final prosthesis.
Mm-hmm.
And with the ArchBridge, we don't have to do that. We can scan from one to the other and send it over, and then try what we call in an iJig. We can talk about that in a little bit to be able to go to our final process. So if we're looking to just do a quick scan so we can get a temporary same day, we can do that using the ROE Dental 1 hour design time. We can do it probably even faster than 1 hour if the design is done, if the workflow is done correctly.
Yep.
The acquisition is done correctly. We have the right photos. We have the facial scan would be great. If you don't have a facial scanner, to look into one. They're phenomenal. We can get all that data in advance and then have it planned. Then the technician doesn't need that long to be able for us to convert over a same day case. And that same day case doesn't have to be surgery. A lot of people think same day is only surgery. Very often I have cases that come in that are implant level cases that we want to change to now multi-unit level because the patient wants to refresh and they've lost some tissue, and now you're starting to see some pink. You want to throw an artificial pink instead of having to do metal and porcelain all over again or a brand new zirconia frame. We switch them over to multi-units. But it's such a pain to take multi-units on, off, on, off. We really don't want to go through that, right. And it could affect our accuracy. So going from implant level to multi-unit level, we can do that and utilize ROE's 1 hour design time. We can print over here with our super fast printer we use from Shiny 3D, the AccuFab Cell, in just about 12 minutes, a full arch. And we can let the patient leave with a brand new set of printed temporaries. So it doesn't always have to be surgery for these temporizations. So it's a really nice technology to be able to take us to that next level at a very affordable method. Because it's made of titanium, we can sterilize them over and over and over again. We can use them multiple times for many patients across the board. Whereas with the OptiSplint, we need to keep it, since sterilizing is really not an option. It has to be kept for that patient. If that patient walks in again and needs to do the lower and you already did the upper, you can break up the OptiSplint and use it on the lower because it doesn't really need to be sterilized. It's from that patient's mouth. Just cold sterilize it for a little bit. That might be fine. But we don't want to transfer this patient to patient. And also that frame that it comes with is they only give you a few frames for that set. So you'd have to figure out how else to lute it together. There are other systems on the market that have these types of long scan bodies that are out there. Mm-hmm. The problem with them is that they are all utilizing the same scan body over and over again. So again, we have the same shaped structure, which becomes an issue for the scanner and may get confused again and think it's somewhere else in the mouth. So we want to try to have different shapes, which is the purpose of the ArchBridge, to help us bridge the arch from one side to the other, utilizing these really nice titanium scan bodies, reusable scan bodies, and be able to connect from one to the other without any disruption in tissue. So if you have a tongue, you have a lack of keratinized tissue, for example, on the mandible, which we very often see. We don't have enough attached gingiva to be able to match to, as opposed to the maxilla, we have the palatal rugae we get to match with. On the lower teeth, it becomes more problematic with the patient moving their tongue around all over. We can just scan from one to the other, picking up the ArchBridge and being able to get it over to our lab technician to be able to either get a same-day printed try-in or begin the finalization process using the iJig method.
Right. Yeah, and that's actually interesting. Very interesting point. A good point on people think about the grammetry process or photogrammetry process, which we're going to go into here soon. It's just day of surgery, but yeah, I mean, there's cases out there, full arch cases walking all around that you need to get to the final. Or like you mentioned, a implant level, and you want to bring it to multi-unit level. And to do that, man, in an analog way is just multiple appointments. It's confusing for the practitioner, and it's not fun for the team. It's not fun
and costly, and very costly.
Right,
I hate to bring that up. I always, I feel bad as a clinician always having to bring that up. I say that at a lot of my lectures about having to worry about finances. But the reality is, if we can't keep costs down, and we have people opening up all around us that are dropping prices, they're dropping prices on implant costs, on final crown costs. You see these advertisements, $1,500 for an implant post and a crown. And how are they doing that? A lot of times they could be using, cheap prosthetics and cheap parts, maybe not using a lab far out away that's really not supposedly, little, maybe slightly unethical, maybe not so
Right.
legal, but they're able to do it. Maybe they do so much volume, they're getting amazing discounts. But what about the regular guy who's regular clinician that's just trying to make ends meet? How are they supposed to do that? Especially when it comes to full arch. If you look at some of these full arch cases, 7 8 visits is the average analog method of being able to do these cases.
Yep.
With the digital workflow, we reduced that to maybe 4 or 5 or 6 visits. If you go into the Grammetry world, now you're looking at 2 visits of finalization, a try-in and a final. And that's really the way to be able to have affordable dentistry for the patient and compete with the people around you, be at a competitive rate. So the ArchBridge works very well for even a novice clinician that doesn't place implants, that's just restoring. You don't have to worry about purchasing that scan body. As long as you're using the multi-unit abutment systems like Nobel, then we can bring in the ArchBridge files and we can turn around these cases in just a couple of visits, make it more economical for the patient, more efficient for your practice, not having to take things in and out all the time from the mouth. That's some of these visits when patients come in and out and you're putting in a new prosthetic and you're squeezing and you're not anesthetizing the patient for a 15-minute trying. So they're not going to like you if you're doing this 7 8 times in, out, in, out. So it's just too much for the patient and the doctor. And by the 8th, 9th visit, when you're trying to get that midline straight and fix things up, nobody likes each other anymore.
Right.
They all want to just put an end to this. So if we can shorten those visits down, get good predictability, and using all the workflows that ROE has, if you look at the website, if you look at the PDFs, if you look at the brochures that you guys have come out with and have helped contribute to some of those in some way, we've really narrowed down the workflows. We've narrowed down the edentulous workflows, the patients that already have temporaries, the dentate workflow, all the different methods. You come in with a denture, we can show you how to go to final. All the different workflows. And on top of that, what Guided Smile and ROE have done together, being able to give out patient brochures so the patient becomes educated, because they can never remember what's going on when they come to the office. They're just looking at the price in the end, and that kind of gets overwhelming sometimes, and a lot of it gets lost through, unfortunately, kind of through the weeds there. So we really want to try to educate our patients, and ROE helps you get there doing that with all the different education materials that you have out there, and then educating the doctor to remember your checklist, to remember what other scans I need to submit for this case. Because maybe I only do one a month. Maybe I'll even do one a year.
Right.
How am I supposed to remember every step for this case? And this case is different than the other case. So how do we bring that all together, and having that workflow both in the PDFs and both in the hard copy, which is nice. I have some of the hard copies here as well, and as well as the brochures for my patients, those little handbooks, giving them the experience and letting them see other cases that have been performed really helps you with not just educating the patient, but also helps you to take that patient and convert them over into an actual case instead of them walking out and going to another practitioner and getting another opinion.
Right.
A lot of these patients are coming in, it might be their 3rd, 4th consult. When they come to our office, we want to be their last consult for this procedure. We want them to use us. And this is the best way that we can do that, is by educating them and giving them the knowledge and letting them walk out with something so they understand it. And if they need to come back, they're coming back to just discuss usually just the financial part of it to finalize that. We try to let the patients handle that same day so we can lock them in, but we're not abusive to our patients. We're not trying to. We want them to be able to make comfortable decisions. If they need to take a day or two, at least they take a day or two, think about it, come back and speak to our financial coordinators. Not so much about remind me again what the process is. We don't have that conversation very often.
Yeah, it's definitely makes that it cuts down those visits, makes it easier for the team, but also for the patient to understand. Now, if you're just getting into full arch or just looking down the road to direct to multi-unit options and photogrammetry and grammetry, I mean, this is a great, I don't want to call it a stepping stone, because this could be your final decision and final workflow. Is the ArchBridge.
Absolutely. Especially for those that have a scanner already.
Right.
You have a scanner, you're not looking to make another investment this year, especially a heavy burdened investment. The ArchBridge is a very affordable method to be able to capture full arch. Whether you do one case a week, one case a month, one case a year, it's affordable, and you're able to make those printed try-ins same day if needed using the Rose Design Services.
Yep.
And if you want to go to final, going direct to zirconia or going direct with Graphene Nano or going direct to resin without using any metal, you can accomplish that on most of the cases as long as the spacing is correct. We can accomplish that on a lot of the cases, be able to go direct to the multi-unit without any metal involved, utilizing some special screws that we can use that in a very affordable, economical method, and that is efficient. We take the tissue scan, we take the ArchBridge scan. If you have teeth in advance, we take the records in advance.
Yep.
We can go through that workflow properly and get the patient some really nice looking teeth. We've been using the bespoke from Roe now, which is the finer finalization of the prosthetics, which really looks beautiful. And we're getting some really nice results direct to multi-unit. But the key is going direct to multi-unit on these cases. I'm not a fan of going direct to implant anymore. I love the multi-unit system. And if you just think about this logically for a moment, because some people ask me, why don't you go direct to implants anymore? Because I used to advocate that a lot. Mm-hmm. And I don't do that anymore because there's always going to be a weak link in the system. The patients will always figure out how to break something. Right. I'd rather that thing not be my final zirconia. I'd rather it not be my implant. The one thing I don't mind breaking over and over again is that multi-unit screw. It can break. I don't have to worry about it. I can remove the multi-unit, place a new multi-unit in. If I keep my records, I have the exact size. I can put a new one in. I can fix that quite easily. What I can't fix easily is a broken implant.
Right.
What is difficult to fix same day, at least, is a broken zirconia. Temporaries, we can print a new one. But a zirconia, we can't do the same day. It has to be remilled. Takes time. So we want the weak link to be the multi-unit abutment. And there is no such thing as there is no weak link, because there's always going to be a weak link and something's always going to break. So I'd rather it be a passively fit structure that maybe a screw might break on the multi-unit, not a screw inside the implant, not a screw, not the superstructure, which is the final zirconia, just having a nice, easy, passive fit. And that's why we choose to go multi-unit level. And that's why we choose to use either the OptiSplint, which is still a great method to use, or the newer ArchBridge, so we can get digital records sent over same day, right over to the lab in a very efficient manner without having to break the bank.
Right. Now, one nice thing about the ArchBridge, of course, is the reusability of it. So you may have a patient that emergency or something broke, or maybe you're a freehand doctor and you can freehand they want the arch that day and they want teeth that day. Well, this is an option. You can go grab your ArchBridge kit because it's titanium, reusable, and you can move forward with whatever the procedure is. Yeah, autoclavable, right. So there's no kind of waiting around and ordering in different pieces, parts. You have it there. Once you have it for all your patients.
That's right.
Which is nice.
And if you lose one, you can buy another one. It's not like some of the other systems that are coded. So you have to buy that specific system together. You can just buy a new one or buy another set, buy 3 sets. It's something reasonable to do. And if you're doing a lot of cases, you can use it. For finalization, again, we do recommend the iJig. The iJig is an amazing product. I think that loses a lot. Some other companies have tried to claim rights to it, and it's kind of funny how 7-8 years ago we were publishing this, and now all of a sudden it's coming out. And you see all these different names for it, but basically what the iJig is basically the structure of the teeth themselves. What we're looking at, and putting in some analogs that we can scan. There's scan analogs onto the actual teeth. And we can do a 360 scan of those analogs and those teeth together. If we can capture that, then we can go ahead and send that information over to Roe. They will then send back a printed try-in. We do the printed try-in, then we can go to the final zirconia. So if you're not adverse to doing one extra visit of doing a try-in, not going direct to zirconia on that visit, the ArchBridge could be a possibility for you to utilize for full arch zirconia replacement as well. So it's not just only for the printed try-ins. We could finalize using that printed try-in method, making sure we have that nice passive fit. And using the right screw system is also imperative for us to be able to control angulations and put things in the right spot.
Yeah, and since you mentioned the screws, what compatibility? It sounds like with the ArchBridge, it's the Nobel well, it is. It's the
Mhm.
Nobel connection.
Nobel system. Yep.
Yeah. So it's your Strummins, your Nobels, your BioHorizons, your a lot of the major implant systems out there. Megagen. Um,
Megagen, yeah.
yeah. So you know,
Yeah,
there's
you have Megagen, Nobel. You have many systems that utilize, and some don't utilize it exactly. They just have a little bit longer type of connection, and we could
right.
still use it on some of those as well. So there's a lot of Nobel compatible systems that are out there that you can use this with. I guess just contact your dealer, make sure, or just contact Roe, because Roe
Yeah.
pretty much knows
We'll tell
the
you.
answer for that. They can tell you which one it is. So we've chosen to use the Vortex screw for this, so that we can get all the benefits of the having the same screw that we want to use for our final restoration or temporary restoration. And for those of you that don't know about the Vortex screw, there's been a big surge in removing metal from the equation. Not every case should have metal removed. Some cases should be bars, but I've never been a fan of tie base caps. They have been a disaster. They debond. They don't leave room for us to be able to have enough zirconia using the traditional screws. But the Vortex screw, when it came out, did two things. Number one, you could use it with metal, so it is possible.
Mhm.
We could use it with a bar, we could use it with a tie-base cap, but it allows for, since a longer screw, it can grab the multi-unit and still allow for more thickness of zirconia around the screw. So we can get less fracturing. I really, frankly, haven't seen any fracturing using the Vortex screw of any cases, but I like to go directly to that multi-unit abutment. Unless I have, let's say, an all-on-4 with big extensions, then I might want to use a bar. The advantage of going with the bar or metal over direct to zirconia, we can do angular screw channels up to 25 degrees using the Vortex screw, whereas with zirconia only, we can do 15 degree. And it's a really nice system because we don't have to screw down all the way. We can do 4 turns, 3 turns, 2 turns with the screw, be able to get it down depending on how much thickness of zirconia you want. So if we have an FP1 case, we might want more thickness of zirconia around that screw. We may not want to take it down all the way, so we get that added thickness. Whereas if we have a very large arch, we may want to take it down because we have so much zirconia anyway, so we can get it seated down further. For areas of lack of occlusal clearances between double arches, we don't have to worry about that. So the gold standard was reducing down 14 to 16 millimeters of bone. We don't necessarily have to do that anymore.
Right.
We can get away with less and handle some of these cases in an FP1 manner, which is no pink, having more natural like teeth. And the Grammetry solution can get us there on both methods, and specifically with the ArchBridge can get us there without having to reuse, being able to reuse scan bodies by having these scan bodies linked from one to the other, getting very close without touching, very close to each other, and being able to capture the arch in a bridge-like fashion and from one to the other, terminal to terminal, without any obstruction.
Right. Yep. Now it sounds like the Vortex screw, that was a very thought out process, and as the wise, because I know there's other screws out there that you cannot change the height of that screw has a system prosthesis.
Right.
That's the great. Right.
There are some great screws. I don't want to knock any other screws. There's the Powerball screw is an excellent screw. You have the Rosen screw is an excellent screw, and you can utilize these for your finals. They work really, really well. And Ro will work with those as well. I've used you for that as well. Des has a new screw that's out there as well. Sin has a screw. There's so many screws out there. I really like what Danny Dominguez has done with the Vortex screw. He's the creator of that, and he and I work together for this ArchBridge to bring this together with Ro, and specifically, you guys really helped us put this together very quickly so that we can get this out there and get this to be affordable for every doctor. And then it has to be something, again, that's repeatable. If I scan, if you scan, the doctor halfway across the world is scanning, we need to be able to replicate that scan. We know we can do that with OptiSplint predictably. And now we're doing the same thing with the ArchBridge. We're getting the same scan, and you can tell when the scan isn't matching because you may see an error. So you can delete the scan over and start over properly. Not every scanner is the best scanner, so we have to be able to accommodate for that. If you have a Trios 5, yeah, of course, it's going to scan in 5 seconds. If you have a Shining 3D scanner like the AeroScan 3, it's going to fly. It's going to pick it up, no problem.
Yep.
But maybe you have an old iTero, and it may not be working as good as it should. So you scan with these scan bodies. You're able to capture everything. Go to a printed try, make sure you have passive fit. If you don't, bond it where it needs to be bonded together. Send it back to Ro. Do one more printed try and go to your final zirconia. It's a cost-effective way to be able to do this. without having to spend a lot of money and without having to do a lot of extra legwork. It's all the same workflow that you were using with typical scan bodies.
Right. Yeah. Yeah. No, that sounds great. And just to kind of summarize, we've touched on a few different topics here within the ArchBridge world. The screws and the scanners and what's compatible. To sum it all up, the ArchBridge, it's a series of unique scan bodies that the doctor, there's no extra equipment they need to buy. It's just their standard intraoral scanner that they have right now. And with a series of records, a photogrammetry type records that, we here at ROE can walk you through that. So if you're just looking into this, don't worry about the records. We'll tell you exactly what records we need, whether it's a dentate case, edentulous case, or if it's kind of you're doing a restorative process. But from this series of scans with the ArchBridge, the reusable titanium scan bodies with the ArchBridge, we're able to design a prosthesis for you to print in office, typically about an hour turnaround time on that, usually less from good records. And then you can print in office and load the prosthesis that day. If you don't have a 3D printer in office, give us a call. We have a great solution with Shining 3D with that. But if you don't have one, we can, of course, do a quick turnaround time on a printed Trine that we print and ship out. We print it in the same day and ship it out next day to you, as long as we have the scans by a certain time, typically 11 a.m. Eastern is when we can get these out to you. But this is an extremely accurate direct to multi-unit abutment solution with just your intraoral scanner to get you the prosthesis to print in office, whether it's day of surgery or on the restorative end. One thing I do want to mention real quick was the healing collars. What is part of this series of scans that we're talking about is capturing the healing collars, a scan of the healing collars on the multi-unit abutments. And we get
that is important.
Yeah, of course. And we get asked a lot, what healing collars can we use? So is there any typical healing collar you have to have, or is there?
You can use any healing collar that's already registered within exocad. For example, the typical BioHorizon healing cap is very common to use. The Nobel healing collar is used, but the Nobel doesn't really have a lot of shape to it. BioHorizon at least has some shape to it. So we could use that. You can match that quite easily. However, ROE has come up with another solution for that as well, utilizing these new healing collars that we made that kind of look like a mushroom type of a shape. These can be 3D printed as well, which is quite nice. And we were able to print them, and utilizing the vortex screw again, we had some geometry placed on the top of the healing collar so that when we do our matching, because keep in mind, all this is going back to a lab technician to do some matching for. When we have the geometry, it's so much easier for the lab technician to be able to match the scans if they have a healing cap that has some known structure on it. And it really makes it simple, as well as having this mushroom shape that it has. It helps to push down the tissue so it stays above that soft tissue, holds things down, so easy to capture. Also, once removed, easy to insert your newly printed temporary restoration that you're using while you're waiting for that 1 hour print or next day print, if that's the case. If it's if you have a slower printer, or if you're using ROE to ship it out, then it'll hold down the tissue until it's ready to be used. One thing I did want to mention about the vortex screw is that the driver is a special driver. We do use the T5 torque driver. We like that very much because of the fact that the T5 is able to be placed on the angle as well. So it does help you to be able to turn the screw. It doesn't have to be directly linked. It can be partially linked to help it drive it down. The other advantage with the T5, if you use the vortex screw, is that if you try to over torque it, it won't strip the screw. The T5 torque driver will break instead of the screw being stripped, because we definitely don't want a damaged screw. That's a pain in the butt to get removed. So don't worry about the screw stripping. The driver will break off instead of the screw stripping. So always have an extra backup just in case you put too much force on, so you can be able to remove it.
Yes, perfect. Love that. So if there's any questions, of course, on the ArchBridge, get a hold of us here at ROE, and we can get that system in your hands and get you going. Honestly, we have them in stock. We can get it to you tomorrow.